Okay, my name is Rachel. I'm going to be doing a chest and thorax exam on my patient Caroline. So to start, I am going to do her posterior chest. So I'm going to have her turn, face that away. So first thing I'm going to do here is inspect. First thing I can see is that her spine is straight. The scapula are symmetrical. Thoracic cage looks normal. It is a bit wider because she is pregnant. Her neck and trapezius muscles are developed normally. She's not using any of her intercostal muscles for her respiratory effort. Her posture and her breathing are relaxed. Now I'm going to move on from the inspection and palpate. So I'm really looking for any masses, tenderness, any areas of crepitus, which is air trapped in the subcutaneous tissue. It all feels normal. And now I'm going to check for symmetrical expansion. So around T9 or T10, I'll kind of pinch up an area. And I'll have Caroline take a deep breath in. And her, the expansion there was symmetrical. I'm going to move on and do a tactile firmness test. Looking at the, well, feeling the vibrations. I'll use the palmar aspect of my hand, place it between her intercostal space, and I'll have her say 99. And what I was looking for there is just symmetry of vibrations, and they were. Now I am going to percuss. So with my non-dominant hand, I'll use my middle finger in between her intercostal space, and I'll just tap there. You're looking for these sounds to be resonant. Dull sounds suggest an abnormal density. And they are ready. Now I'm ready to auscultate her breath sounds. So I'll just tell the patient prior that I need them to take a deep breath with each touch of the stethoscope. I'm going to start around C7, avoiding the scapula, using a ladder approach down to T9 and then lateral to the axilla, around the 7th or 8th rib. Okay, there I was looking for any adventitious breath sounds, any crackles, wheezing, coarseness. Her lung sounds are clear bilaterally. Um, and then to end the posterior assessment, I'm going to do the transmitted voice sounds. So that starts with the, I'm going to start with the bronchophony. So I will have the patient, I will listen as they say, I'll have her say 99. And what I want to hear is, I want her voice to sound muffled as I listen. Clear sounds would indicate a consolidation, since sound travels through areas of density better. So I would be able, if there were, she could have pneumonia in an area or any area of consolidation, I would be able to hear her clearly. It wouldn't sound muffled. So I'll tell the patient ahead of time, when I touch my stethoscope to you, say 99. 99. Okay, and her sounds were muffled. Now I'm going to do the whispered pectrology test. So I will have the patient whisper 1, 2, 3 with each touch of the stethoscope, and it's the same principle here. I would be able to hear her if there was an area of consolidation. If her lungs are clear, then I should not be able to hear her. Okay, and I could not hear her, so her lung sounds are clear. Now I'm going to do the Egophony test. So I'll have the patient say E with each touch of the stethoscope. If there was an area of consolidation, the E sound would sound more like an A sound. So I'm looking to hear an E, a muffled E sound. E, 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 Okay, and I did hear an E sound. So now that concludes the posterior part. I am going to have the patient turn, face the camera, and I'll move on to the anterior chest. So first I'm going to start just by inspecting the thoracic cage. It is symmetrical. Her ribs are downward sloping. And like I said, she is pregnant, so her thoracic cage is a bit wider than her normal. Her posture again is relaxed. Breathing pattern is relaxed. She's not using any of her intercostal muscles for her respiratory effort. Now I am going to palpate for any masses, tenderness, any areas of crepitus. There are none. And now I will check for symmetrical expansion. So I am having my hands spread kind of outward. I am pointing my thumbs up towards the xiphoid process and pinching a small fold of skin, and I will have the patient take a deep breath in and out. And that was, her chest is expanding symmetrically. Now I'll do the tactile firmness test. So again, I am taking the palmar aspect of my hand into the intercostal space and having the patient say 99.
99, 99, 99, 99, 99, 99, 99, 99.
Okay. And those vibrations were symmetrical. Now I'm going to move on and oscillate her lung fields. So starting supraclavicularly. And I'll preface by telling the patient to take a deep breath with each touch of my stethoscope. Okay, and I didn't hear any adventitious breath sounds there. They were clear bilaterally. Now I can move on and do the voice transmission tests again. So starting with the bronchophony, I will have the patient say 99 with each touch of my stethoscope.
99, 99, 99, 99, 99, 99, 99, 99.
And again, those sounded muffled, which is what we want. We don't want to hear any clear sounds there because that would indicate areas of consolidation. Now I'm going to do the whisper pectrology test. So I'll have the patient whisper 1, 2, 3, which with each touch of my stethoscope.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay, I couldn't hear her through my stethoscope, which is good. Now I'm going to do the egophony test. So I'll have the patient say E with each touch of my stethoscope.
E, 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 E.
Okay, and those all sounded like E's instead of the A's, which indicates clear lung fields. Okay, so now I am ready to oscillate heart sounds. So you want to use the bell and the diaphragm for this. I'm going to start with the diaphragm. Listen to all 4 valves. First I'll start with the aortic, which is the right sternal border, second intercostal space. And I'll go to the pulmonic, which is the left sternal border, second intercostal space. Then I'll move to the tricuspid, which is the left intercostal, left sternal border, fourth intercostal space. And then I will move to the fifth intercostal space, mid-clavicular line, and listen to the tricuspid. Or, I'm sorry, listen to the mitral. I just listened to the tricuspid. So mid-clavicular line, fifth intercostal space, to hear the mitral valve. Okay, now I'll listen with my bell. Right sternal border, second intercostal space for the aortic. Pulmonic is left sternal border, second intercostal space. Tricuspid is the left sternal border, fourth intercostal space. And the mitral is the midclavicular line, fifth intercostal space. Okay, and with all those sounds, she had a very clear S1, S2. There were no extra heart sounds, no murmurs that I could hear. Now I'm going to listen to her apical rate and rhythm. It's at you're listening at the apex of the heart, so fourth or fifth intercostal space, midclavicular line. Okay, so her rhythm is regular. Her rate is about 70 to 80. And now I am ready to palpate her carotid artery. So that is going to be medial to the sternomastoid muscle. I'm going to palpate that on the lower region of the neck to avoid the carotid sinus, which could cause the patient to brady down. You don't want to apply too much pressure. You would do this on both sides. Okay, so with that, she has a smooth, brisk upstroke. I couldn't feel a thrill. Amplitude was moderate. I'm going to auscultate the carotid artery. I'll use the bell and the diaphragm again. I'm looking for a bruit. I'll listen at three different spots here. One at the angle of the jaw, mid-cervical, and then in the lower region of the neck. You would do that on both sides. So here, if you were concerned that you heard a bruit but weren't sure, you could have the patient take a deep breath in, exhale, and then hold their breath. That way you can make sure you're not confusing their breath sounds for a bruit. Also, with the auscultation of the valves, you can have if you're worried you're hearing a murmur, you could have the patient lean forward and listen to the heart sounds there, and you could hear any soft insufficiency murmurs. But that concludes my chest and thorax exam.